Surgical Radiography I by Brandy Jones. Essential attributes of the radiographer in surgical radiography: confidence, communication, problem-solving skills, and mastery. Confidence is judged by the technologist's level of comfort and ease in the OR suite. The surgical team expects this technologist to perform quickly and accurately. Confidence will grow with experience. Communication. Clear communication between the technologist, surgeon, and the staff is paramount. Problem-solving skills. Even when the technologist has the best skill, knowledge and preparation of unexpected problems can still occur during surgery. The C-arm can cease to work, reliable exposure factors may fail and to produce diagnostic images, or maybe the sterile field may be violated. The tech should be able to solve unforeseen situations. Mastery of the C-arm and the portable radiography unit. Must be able to operate and troubleshoot digital and conventional equipment. The technologist must know reliable exposure factors that will work for patients of different sizes and different procedures. The surgical team. Surgeon, a physician licensed and trained in either general surgery or a specialty such as orthopedics. The surgeon has the primary responsibility for the entire surgical procedure and for the well-being of the patient prior, during, and after surgery. An anesthesiologist, a physician or a certified nurse who specializes in administering anesthetic drugs to induce and maintain anesthesia to the patient during surgery. A surgical assistant, a physician or a physician assistant, certified surgical technologist, or a registered nurse who assists the surgeon. This responsibilities may include sectioning, tying, clamping blood vessels, and assisting in cutting and suturing tissue. A CST is a health professional who prepares the OR by supplying it with the appropriate supplies and instruments. They also help prepare the patient for the surgery and connect surgical equipment and monitoring devices. During the surgery, they maintain the sterile field. A circulator is a non-sterile CST or an RN who assists in the OR by responding to the needs of the scrub members within the sterile field before, during, and after surgery. They record the patient information, retrieve supplies, maintain account of the items being used, and they connect non-sterile monitoring equipment. A scrub, a CST or an RN who prepares the sterile field, scrubs and gowns the members of the surgical team, and prepares and sterilizes the instruments before the surgery begins. The equipment. Cleaning. Make sure your portable or C-arm is clean before going into the OR, and it must be cleaned on the way out. An approved antiseptic cleaner should be used to wipe down the equipment. Image receptors and grids should be inspected for contamination and cleaned weekly. Operational check. Before imaging equipment is used, a operational check should be performed. A portable machine is a lot easier than a C-arm. Proper equipment location. Know what outlets to use and data ports to use for PACS. The monitor should be placed in a position for the surgeon and the C-arm when needed. Mobile C-arm. Familiarity is essential for the radiologic technologist. Know your equipment. Know that the surgical table will not work for your C-arm before the patient gets placed on it. Mobile C-arm. Maneuverability. It is a flexible unit with built-in joints, extensions, and adjustments, steerable base with a C-arm portion that can be rotated 180 degrees. Display monitors and control cart. Two monitors generally used. A active image can be displayed on the first monitor, while the second may be used as an image hold. Uses of C-arms. Common surgical procedures include cholangiography, open and closed reductions of fractures, hip pinnings. Images can be uploaded and stored to PACS. Controls and operation modes. A variety of mode control options. For example, magnification mode, pulse mode, a snapshot or digital mode, a auto manual exposure control for subtraction and road mapping only. A foot pedal allows the physician or the operator to stand hands-free. It has the same controls as the hand paddle and allows for you to stand 6 feet away. Image orientation. The flexibility of the C-arm for the imaging is a variety of anatomic structures at almost any conceivable angle from any side or direction requires correct image orientation at each time that it is set up. This should be done at the beginning of the case. Image orientation. Radiation protection in surgical radiography. Staph exposure is the primary source of radiation exposure from scattered radiation from the patient. Everyone should protect themselves with a minimum of 0.5 millimeters of lead or equivalent, which reduces the exposure by 50%. Radiation protection practices are very important in the OR for all the personnel during mobile imaging. There are several ways to practice good radiation protection in the surgical suite. Provide adequate number of aprons for all personnel. Wear your thyroid collar. Secure aprons tightly to prevent from touching sterile fields or sterile personnel. Clean the aprons often or as needed with liquid type cleaner. The C-arm has a foot pedal and an exposure switch that both allow you to step a minimum of 6 feet back from the tube. Check the aprons for cracks in the lead lining. Most facilities will do this annually. Radiation protection. Provide all the protective lead aprons to all persons remaining in the room during surgery. 3 cardinal rules in radiation protection are time, distance, and shielding. Make sure all personnel are wearing their dosimeters. This dosimeter should be worn above the lead at the collar level. Here are some images of a C-arm in some cases. C-arm orientation and exposure patterns. A vertical posterior anterior projection, CR. The patient is supine. The tube is located below the patient, hence the PA projection. The II is located directly above the patient and perpendicular to the floor. This will minimize exposure to the neck and facial region. If a C-arm is tilted as much as 30 degrees, exposure increases significantly to the upper body and face that is not shielded by lead aprons. Studies have shown that even 30-degree C-arm tilt will increase the dose and the face to the neck region of an operator on the average height who stands next to the C-arm by a factor of 4. A horizontal projection CR, the exposure region of the X-ray tube side of the patient is significantly larger than in the region near the II. This is huge considering for the surgeon or the other operator who may need to stand next to this patient. A vertical AP projection CR. Occasionally, the CR may be reversed so that the tube is on top and the II is under the table. This is not recommended. However, it may happen. The significant increase in exposure to the operator is up to 100 times higher close to the eyes of the operator. Patient dose. The exposure rate depends on the operational mode, the field size, the patient size, the tissue composition, and the ABC design. ABC stands for Automatic Brightness Control. Summary of radiation protection in the surgical radiography. Time. The use of intermittent fluoro, a single exposure capacity, can greatly reduce fluoro time. Image hold feature allows the last image to remain on the monitor. Minimize boost exposures. The boost feature on most C-arms provides an improved and brighter image for the large body habitus or thick anatomy. However, this feature increases radiation, primary MA, which also increases exposure to the patient and surrounding surgical team by a factor of 3 to 4 times compared with the regular fluoroscopy. Distance, vertical alignment. Place the vertical alignment of the C-arm so the X-ray tube is far away from the operator's head and neck. This is achieved by placing the X-ray tube beneath the OR table, thus reducing the dose to the head and neck region of the surgical team. Minimize distance between the anatomy and the II. Reduce distance between anatomy and the eye creates a brighter, sharper, less magnified image with a reduction in radiation to the immediate area. Shielding, protective lead aprons. Everyone wears a lead apron and a thyroid collar. They must be secure to prevent accidental touching of sterile field. Clean aprons need to be with a liquid type cleaner. Check aprons for any cracks. Continued summary, radiation protection in surgical radiography. Communication, coordination of the exposure with the surgical team. Coordinate among the anesthesiologist, surgeon, and surgical team. For example, a surgery, cholangiography, injection of contrast media, and suspension of patient breathing and X-ray exposure must be closely coordinated to get a great image. The tech should announce X-ray before initiating an exposure. A monitoring of your personnel dosimetry report. Technologists who perform CRM procedures should closely monitor their report. If you have high levels and work habits might need to be modified. Surgical asepsis principles. 8 principles to reduce the risk of infection during surgery. 1. Only sterile items are allowed within the sterile field. 2. If the sterility of an object is in doubt, it must be considered non-sterile. 3. If a sterile drape or cover is touched by a non-sterile object or person, it must be considered contaminated. 4. Non-sterile personnel must not come in contact with a sterile barrier, drape, or surgical instrument. 5. Any contaminated sterile drape or cover must be reported and replaced by sterile personnel. 6. Sterile gowns are considered sterile from the shoulder level to the level of the field and the sleeve from the cuff just about to the elbow. 7. OR tables are considered sterile only at the level of the tabletop. 8. Only sterile personnel can touch sterile items. Surgical suite environment. The typical surgical suite has 2 general regions known as the sterile and non-sterile areas. Sterile. It consists of the patient, the surgical field, the surgical assistants, the tables, and the carts. Often, the sterile field is located on one side of the room. The technologist or the X-ray equipment must not violate the sterile field. Non-sterile. It consists of the radiologic technologist as well as other non-sterile surgical personnel, such as the anesthesiologist and a circulator. The technologist can safely stand and operate the imaging equipment within this area. For select procedures, a plastic drape or a shower curtain can be a divider with the sterile and non-sterile fields. Draping the C-arm. There are 3 methods to drape the C-arm and make it safe to operate in the sterile field. 1. Draping the C-arm with a sterile plastic C-arm cover. 2. Draping the C-arm and the intensifier with a snap cover. 3. A shower curtain. Image receptor plastic covers. When an image receptor must be used within the sterile field, it must be placed in a sterile plastic cover. Keep in mind that only the outer surface of the cover is sterile. The inner surface of the cover is non-sterile and comes in contact with the IR. Surgical attire. 8 items that make up surgical attire. Scrubs, scrub cover, head cover, shoes, mask, protective eyewear, and non-sterile gloves. Surgical attire. Scrubs, a low lint producing material that minimizes bacterial shedding. 2-piece scrubs should fit properly. Some facilities require scrub jackets. These scrubs are supplied by the facility and are to be returned to be laundered. If they become soiled by blood, perspiration, or food, the scrub should be changed. A scrub cover. Button or snap covers worn in between procedures, designed to prevent soiling or cross-contamination. These are to be removed before re-entering the surgical suite. A head cover. Proper fitting head cover, a bouffant, or hood types of covers are preferred because they are the best cover. All hair must be tucked in. Hood type cover the beard and or facial hair and discard after each procedure. Continued surgical attire, shoe cover, designed to keep the shoes clean and decrease quantity of soil and bacteria trapped in the surgery suite. Change if they get soiled or torn. Shoes. Soft cloth shoes should not be worn. A durable shoe with plenty of support, closed hard toe, and heel minimizes injuries caused by falling objects, needles, or cassettes. Masks. A surgical mask must be worn to reduce the dispersal of microbial droplets from tech during surgery. A single high filtration mask is recommended. Masks must be changed between procedures or when moisture is detected on the outside of the mask. Continued surgical attire, protective eyewear. Not necessary for most procedures, but a good idea. It protects you from bodily fluid, tissue debris. Specialized lead eyewear is worn to protect the eyes from radiation from long-term exposure. Non-sterile gloves when handling contaminated IR cassettes, soiled IR covers, or when cleaning equipment after procedures. Once gloves are removed, wash your hands. Sterile surgical attire versus non-sterile or surgical attire. Surgical radiographic procedures. Biliary tract procedures. Cholangiography is a surgery to demonstrate anatomy of the biliary duct system, drainage into the duodenum, any residual stones in the biliary ducts. In many cases, the patient has history of gallstones, usually performed before removal of the gallbladder, but also can be performed after as well. The surgeon places a small catheter into the biliary ducts, injects 68 milliliters of iodinated contrast media. The respiration can be suspended when coordinated. This can be performed in two ways in the surgical suite. One with a C-arm positioned in vertical position, sterile fields maintained, sterile drape over the image and intensifier. Mobile radiography, the surgical site is covered with a sterile drape. The IR is placed from the head of the table and slid down the surgical table into the abdomen. While keeping all sterile fields in place, most of the time you need to ask them to lower the kidney rest back down inside the table to get the IR to the desired point in the table. Center your tube over the patient and IR. The area of interest is the right upper quadrant of the abdomen. Laparoscopic cholecystectomy provides a less invasive approach for removal of the diseased gallbladder. The surgeon will make a small incision in the umbilicus to pass the endoscope into the abdomen cavity. Three advantages. One, it can be performed as an outpatient procedure. Two, with it being minimally invasive, the 2-day hospital stay is not a standard anymore. And number three, the reduced cost due to number two. Images obtained. 2, but preferably 3 images. An AP, a slight posterior RPO, projects biliary ducts away from the spine, and a slight LPO. Retrograde urography is a non-functional exam of the urinary system which contrast is directly injected backwards, retrograde, with a catheter. The urologist usually will perform this minor surgery to determine the location of obstruction or undetected calculi. The study may also be performed to study the renal pelvis calyces for structural defect or infection. This can be performed in 2 ways. A cystoscopic radiographic table. It has dedicated x-ray tube and also has fluoroscopic capabilities. Or 2, a C-arm, position in vertical position, sterile fields maintained, a sterile drape over the patient's abdomen. A C-arm drape is not usually needed for this type of setup. Patients are supine on the table with legs in stirrups. The urologist uses a cystoscope through the urethra into the bladder. The urologist may insert a cystoscope into one or both ureters. The contrast can be introduced depending on the area of interest. Images usually obtained. A scout, a retrograde urographic series or pilogram, which injects 3 to 5 milliliters of contrast through the catheter to the renal pelvis or one or both kidneys. Usually a final image, a ureterogram, which withdraws the catheter and simultaneously injects contrast to one or both ureters. Orthopedic procedures intend to reestablish the length, strength, or alignment of fractured bones, restore function, range of motion to joints affected by trauma or diseases. Radiography is required for many of these orthopedic procedures To provide guidance for the surgeon during insertion of various orthopedic devices, this can be performed in two ways in the surgical suite, one with a C-arm and two with mobile radiography. Orthopedic surgical terminology. Closed reduction. Fragments realign by manipulation and are immobilized by a cast or splint. Non-surgical procedure, meaning the fracture site is not cut open but may have small pins placed through the skin of the patient into the proper location and removed later. Open reduction. Severe fractures with displacement or fragmentation. A surgical procedure is required. The fracture site is exposed, and a variety of screws, plates, and rods are inserted to maintain alignment. This is called an ORIF. Internal fixation. During an open reduction of fractures, a variety of compression plates, screws, pins, intramedullary rods, nails, or wires are applied to reduce and realign the fracture. These devices are left in place while the skin is closed around the devices. In some minor surgeries, these may be removed later. Continued orthopedic surgical terminology. External fixation. A external fracture stabilizing device permits bone to heal with the immediate requirement for internal fixation. External fixators can also be used with internal fixations. Indications for external fixation device include severe open fractures, comminuted closed fractures, infected joints, major alignment, and other length deficits. Intramedullary fixation. Rods or nails are inserted within the shaft of the long bones to stabilize. This is popular for reducing shaft fractures of the humerus, tibia, and femur. Hip fractures. Proximal femur or hip fractures are classified according to their location. These fractures require ORIF. Common hip fractures are femoral neck, intertrochanteric, and subtrochanteric. Internal fixation devices for hip fractures require the use of cannulated screws, compression screws, lag screws, and a plate combination of pins. The patient is placed on a special fracture table that permits traction. The fracture is reduced through traction and manipulation, and an incision is made at the level of the greater trochanter. Guide pins are inserted through the fracture to stabilize it. For femoral neck fractures, once guide pins are aligned, large screws or other internal fixation pin is placed through the fracture. With the fracture table, the shower curtain type of isolation divides the room and allows for easy access and movements for the C-arm. A C-arm must be placed so it can freely be moved from PA to a horizontal beam. Laminectomy, a surgical procedure performed to alleviate pain caused by neural impingement, designed to remove a small portion of bone or herniated disc material impinging on that nerve root. This is intended to free up space around the nerve root based upon the number of vertebrae in which the surgeon operates during a laminectomy. An additional procedure called a spinal fusion may be needed. Spinal fusion uses rods, plates, and screws to stabilize the surgical altered vertebrae. Interbody fusion cages or devices are another alternate to traditional spinal fusion, or the use of pedicle screws to stabilize the vertebrae. The cages are titanium filled with bone that are inserted between the vertebrae bodies to maintain disc base, height, and fuse the joint, eliminating abnormal movement. Laminectomy is also effective in decreasing pain and improving function for patients with lumbar spinal stenosis. LSS usually afflicts older patients. Degenerative changes can be performed on cervical or lumbar region. Cervical region is performed to remove bony obstructions such as bone spurs, osteophytes, and herniated disc materials impinging on the spinal cord or nerves. Lumbar laminectomy is performed for a myriad of reasons, including bony obstructions, stenosis, and spinal cord impingement. Laminectomy continued. They may require a C-arm or mobile radiography. The role of the radiographer is to confirm the level of the vertebrae and may provide guidance if orthopedic plates and or screws are used during surgery. The C-arm must be free to move from a PPA to a horizontal beam for the lateral. A sterile drape is placed over the II. When going lateral, a drape will be required for the tube as well. The C-arm must be parallel to the vertebrae to avoid distortion of visible structures. Pacemaker insertion. A implantable permanent device implantation is performed under local or general anesthesia in a hospital by a cardiologist. A insulated wire called a lead is inserted into an incision below the clavicle and is guided through a large vein into the chambers of the heart. These electrodes stimulate the heart muscle, causing it to beat at a predetermined rate. This process is called pacing the heart. The electrodes are inserted through a vein in the arm or chest and advanced to the right ventricle under fluoro. The C-arm must be free to move easily from PA to a horizontal beam, a lateral. Sterile drapes are required. Post-op chest x-ray is required to ensure proper placement of the leads. It should be performed erect as possible. The end.